can look at the data overall, right? So we're looking among everybody who is in this model, and it's important to note that this model is really focused on subgroups because we know that people with HIV in the United States, it's a heterogeneous group of folks, and so we want to be sure that we're not overlooking any subgroup. So when we built this model, we actually started with 15 subgroups of interest. So we look amongst white, Black, African American, and Hispanic individuals. And within those three race and ethnicity categories, we look at 5 groups that are defined by both gender and HIV acquisition risk factors. So we have men who have sex with men, and we have men who inject drugs. We have women who inject drugs. We have heterosexual women, and we have heterosexual men. And so we can look to see what the future may be holding for the overall importance of the different comorbidities, but we also take the step to look within each group. So overall, what we see is that we see a lot of anxiety and depression, and it continues to rise. We also see high levels of dyslipidemia that are rising. Interestingly, we see hypertension, which is a higher prevalence, around 40%, but it's plateauing. Chronic kidney disease, that continues to increase, and diabetes as well. Now, those start off lower prevalence and move up over time. For our later stage and oftentimes more serious illnesses of cancer, end-stage liver disease, and MI, we see cancer kind of staying at a 10 to 15% prevalence and pretty much holding tight. And we see end-stage liver disease, that's a much lower prevalence, around 1 to 3%, and that is proceeding throughout the next few years. But we do see an increase in the prevalence of myocardial infarctions. And that makes sense when we think about the fact that diabetes is also projected to be on the rise. And I think, and chronic kidney disease, because those are important risk factors for myocardial infarction. Those are telling us, yes, we definitely need endocrinology. We definitely need nephrology. We need mental health professionals to also be integrated into the care of persons aging with HIV. But it's also important to note that what are, for example, white men who have sex with men and gay men will be experiencing in terms of their comorbidity forecasts. It is not the same as what, for example, our Black African American women who inject drugs are experiencing. And so we'll also be presenting some of those differences. And overall, we see, mental health conditions and dyslipidemia on the rise in white MSM, whereas for our Black women who inject drugs, it's chronic kidney disease and diabetes, increasing at these really high rates that are concerning to us. At the individual level, for persons who are living with HIV, it's important to note I'm not a clinician, I'm an epidemiologist, but what the data are showing us is the same thing we see in the general population. Preservation of health at younger and into middle age really does pay off, right? So that is something our data are showing as well. So things like smoking cessation, weight maintenance, diet and exercise, those lifestyle risk factors that could potentially be changed are important for individuals to consider. But with this model, we actually want to push past this individual level situation, because it's also important to note that among persons with HIV in the United States, there are different barriers to things like fresh fruits and vegetables, to safe places to exercise, to all of these different things, because people with HIV in the United States are a heterogeneous group living very different experiences across the board.